Well, welcome everyone. I'm Nicholas Torres. I'm the interim president and CEO of the Alliance for Health Equity, and we're so happy to be here with you. It's been a long year and a half journey to get us to this point and really share with you what we've been doing collectively with a cross-sector convening and provide you with the information we have today. I'm joined here by my colleagues Lissette Vilarchao and Mike Clark, who partnered with Dr. Scott Spriet, who did the analysis of this survey. What we're presenting you here today is this is in response to when the Brandywine Hospital closed back in February 2022. And in response to that, a group of cross-sector convenings of government, community members, nonprofit service providers, and other leadership within Greater Coatesville came together and said, how do we tackle the issue? More importantly than how we tackle it is what solutions we can present. So what you're going to hear today is a little bit of the history of the convening. And then you're going to hear from us the analysis. What did the 1,200 survey data produce in terms of the analysis of that? And in my mind, most importantly, is going to be not necessarily what the data said, but what we're planning to do about it to make Coatesville a greater community and a stronger community, not only in healthcare delivery, but many other aspects. Next slide, Lisa. So what you're going to hear today is the welcome, of course. We're going to give you the Community Health Survey Framework, which is a little bit of a history of how this came to be, the current findings, some survey recommendations, and then we'll pause and to see if anybody has particular questions regarding that. And then we're going to move into the more dynamic part of the symposium but we're going to present to you what the group came back in terms of what action steps we're planning to do starting in July 2023 through June 2024, leading to hopefully some big impact goals by 2026. And so we want your feedback on those particular goals. And in that, we're going to break into breakout groups under 3 themes. One is integrated health delivery. One is access and engagement of community residents. And the last is social determinants of health, framed within a living wage and affordable and stable housing. And then we're going to come back and listen to each other about what each group discussed, and we'll finalize it with next steps. So now I'd like to turn it over to my colleague, Lissette.
Good morning, everyone. So a little bit of history. So as most of you might know, the Brandywine Hospital in 2018 had a community health needs assessment performed, which really provided us with a framework and a baseline for what to look for when we launched our own survey. So after the closures of the hospital in late 2021 and 2022, the hospital closure group in 2 forms, advocacy and coordinated health groups, formed in 2022 to look at and develop strategies on how we could mitigate these effects of the hospital closures that were, of course, capitalizing on the effects of COVID-19 pandemic. So in 2022, with the partnership of Chester County, the Alliance for Health Equity conducted a health survey that really determined the impact of the closures and the pandemic on the community and assessed what the community's health status was at the time. When we received those responses, we recognized that the responses as a whole were very reflective of Chester County as a whole, rather than the Coatesville community in particular. So also in 2022, the Alliance for Health Equity, along with 2 community partners, were able to gather data from groups that it was important to represent and that had not been represented in the larger strategy and the larger survey. In 2022 as well, with a grant from the American Rescue Plan, the Equity Health Center was launched with a plan to provide integrated healthcare through providers, which you will hear a little bit more of later on. And in 2023, as we will discuss later on as well, the Alliance for Health Equity launched Anchor Strategy, a place-based approach for health equity in Greater Coatesville, comprised of the 3 groups that Nick was referring to earlier, that we will go into breakout rooms and discuss those 3 topics of the integrated healthcare delivery, our access and engagement strategy plans, as well as our social determinants of health, focusing on employment and living wage and affordable housing. I'm going to turn it over to Mike, who is going to discuss our survey analysis findings.
Thanks, Lissette, and thanks, Nick. This was such an interesting survey to work on, and I want to give a shout out. Nick mentioned him earlier, Dr. Scott Spreet, who's the Vice President of Evaluation and Research of Wood Services, which is one of the largest intellectual disability service providers on the East Coast. And he leads a lot of research nationally in that area. I know that he was very excited to get into and look at a health equity lens and look at this community in particular. Hopefully I can fill some of Scott's shoes here. He's a great person to talk to if you ever get a chance to get some of his feedback on survey analysis and data and research. He's led some really nice research related to workforce and many other things in healthcare and IDD space. But to get into this survey, it was very interesting. And I think when we talk about surveys, we don't necessarily put an equity lens on surveys, right? But I want to commend the group that pushed this when they looked at the initial data collection, because that first data collection, as you see, excuse me, sample A, I mean, that's a great sample size for a survey to do some good analysis on. It had 604 people respond. But when you look at some of the demographics, and this is detailed further in the written report, and how it compares to Coatesville in particular, there's a little bit of mismatch there. So the percent of poverty is 8%. The median family income of this sample A was over $90,000 a year, and Medicaid insurance was about 22% of the population surveyed. So this more represents or closer represents the county as a whole. It doesn't necessarily represent the city of Coatesville. So the Alliance, Lissette, Nick, the staff, along with some service providers, really looked at bringing in other groups that would give more of a representative sample. So these samples, sample A, sample B, excuse me, and sample C, they're all treated as distinct samples, but we're going to juxtapose them and put them side by side to paint, I think, a pretty interesting mosaic of health equity and health equity gaps in this geographic area. So if you sample A, that's the largest sample at 604. Sample B is a sample of 397. This was conducted by a coalition of service providers, and sample C was the Maternal Health Consortium at 136. So we're going to be talking about these samples throughout. If you want to think about them, sample A, those are a little bit of a higher number, both in sample size. It's the highest sample size. It's also the highest income level. Sample B is a lower income level, but the second highest income level, and then sample C is the lowest income level there. I also want to shout out that the sample C, there's some really interesting nuances there that I think we uncovered in the survey that you're going to see throughout. And as you see, 75% of that population is on has Medicaid as their primary insurance. So next slide, please. So there's 10 questions, and they're all fascinating. I highly encourage you to read the report, the full report. We highlighted some of them that, again, I think paints a pretty interesting picture here. So this is a question around ease of healthcare access. So this is the percent of those populations that say accessing healthcare is easy, right? So for sample A, 57% said it was easy. Sample B, 18%, and sample C, 6%. So that says a few things, right? Sample A perceives healthcare access, the ease of healthcare access, at the highest level. Sample B, second highest level, and sample C, third highest, low at 6%. But if you look at that bottom right corner, the sample C population, 106% of the respondents said neither, right? So they said neither easy nor difficult, which starts to signal some things, right? Starts to signal that maybe they don't have the same level of interaction, right? Maybe with the healthcare system as the other two populations. And we kind of see that throughout the findings. Another note here around ease of healthcare access, the populations B and C had similar questions posed. For sample A, we took the larger primary care question and applied that to healthcare access. So you're going to start to see some trends emerge here. Next slide, please. Sources for healthcare advice. So this is the percent indicating that they have a source for healthcare information. And this is really around a sole source for healthcare information. We looked at healthcare in general, mental health services, and then also drug and alcohol services. So sample A, the population, 84% have a primary source of advice, a primary provider. primary source to go through for healthcare information. Sample B, that number was considerably lower at 33%, and sample C, lower indeed at 11%. So you kind of see this cascading impact throughout the survey groups. And if you don't necessarily have a primary source of healthcare advice, that might leave you a little bit outside looking in when it comes to access for the healthcare system. Next slide, please. Distance and transportation. So this is another really interesting thing that was uncovered during these three distinct surveys, these three distinct samples. While sample A did pose some transportation challenges across multiple provider types, whether that's primary care providers or specialists or retail health clinics, it really looks at sample B reported the most difficulty out of the three samples. So sample B, although sample A did have some challenges, sample B also reported the most difficulty in accessing healthcare services. Now sample C, while they scored and responded lower on some of these other indicators that you've seen, they reported the least difficulty, which is really interesting. And start to ask why. So the sample, that sample C is accessing healthcare services generally. They're utilizing healthcare sources across the board less. So this is really equating less difficulty in accessing services due to distance and transportation because they're accessing the services less. They're again, don't necessarily have that primary advisor, don't have that source of advice in the healthcare system, and there's additional barriers for that sample C to access the healthcare system. Next slide, please. So the use of a healthcare portal, again, another kind of fascinating thing that came out of this survey and these three sample sizes. So sample A, 86% have used a portal for healthcare, used some sort of technology to access healthcare and access healthcare information. Sample B, about 45% used a portal for healthcare, and sample C, 70% used a portal. So this shows a little bit of a, not a little bit, a lot of a technological divide. So I will also work on healthcare policy at the federal level for looking at telehealth policy. And at the onset of the pandemic, saw an explosion of telehealth usage, right? 7,000% increase in telehealth usage. Went from about 850,000 people across the country using telehealth to over 52 million. But there are certain people that have been left out of that explosion, have been out of this great new access point or newly adapted access point. Newly adopted, let me say, access point to access healthcare services and engage in healthcare services. So our sample B and our sample C they highlight a bit of a access divide here when it comes to technology, telehealth, telemedicine, remote patient monitoring, anything that has a technological aspect to it. The portal is an indicator of that. The portal is an indicator of other impacts and lack of access to certain forms of technology when it comes to engaging in the healthcare system. Next slide, please. So some of the survey recommendations, and I think like Nick said, that definitely the most interesting part of today is, what do we do about this information? So it's not only about accessing or increasing or enhancing access to care, it's also about building education, creating incentives, and engaging people in the healthcare system that feel left out of the healthcare system or don't engage in the healthcare system to begin with. So it's not just creating new points of access, by increasing transportation and increasing, behavioral health services, expanding retail health clinics, urgent care clinics, expanding the services of federally qualified health centers in the region, CHESPEN. All those things are incredibly important to create additional points of access. But there's also this, I think you'll see this in the upcoming slides and some of the discussion today. There's a need to really look at engagement as well. So pulling people in the healthcare system that might not be a part of it or might not feel like they are a part of the healthcare system. So I encourage you to read the report. That's a very high level overview, but I'm open right now to answer any questions that you may have on the slide so far.
So for this questions, on the bottom of your screen, there's a reaction tab that will allow you to raise your hand, or you can put the question in the chat box. But we wanted to make sure we pause and allow any questions that you may have. So first question is from Helen. Could you please return to the last slide? Didn't get out my notes. Okay, you want to go back to one slide? And the full report. And so we will be publishing the report. We will also, we have your registration here, and we will be able to, you can either pick it up or we can send it to you. But we will, once the full report is public, we'll make, but we're not, the full report, which is what Mike and Dr. Scott Sprea did, was very long. And so we've condensed it into a publication of the Alliance for Health Equity that we will make sure that everybody has access to it. First question, Mike, is can you mention how the samples are received and more description of each sample?
Sure, yeah, and maybe Lissette can jump in here too. So the samples were received initially. That first sample was received by mainly online survey. Samples B and C were a mixture of outreach, paper, home visits, and actually on-site survey, filling out the survey itself. The populations, I think, really represent, like I said, sample A is more representative of the county than it is the Greater Coatesville area, although it was distributed to the Greater Coatesville area. Sample B and sample C represent populations that have a lower economic bracket. So I don't know if you want to add to any of that.
No, that's exactly right. I think the only thing I would add is that to Mike's point about the divide in technology, we really learned in the expansion of the survey that how we gather data is also very indicative of how we can engage the population. So it provided also a solution, or at least a strategy on how to further engage.
And the question from Amanda Winky is, will we ever have a hospital in the Coatesville area? Amanda, our understanding is Tower Health is in negotiations with one particular provider. Other than that, timing of that, we don't have the answer to that. But part of the solution that we will be presenting next in the second part gets into what can we do to make the ecosystem of Coatesville greater. So that would be a great when you join the other groups. Megan asks, I'm curious as to if it got specific on the type of healthcare the response we're referring to. For example, are those in sample C less likely to get preventive routine care, where sample A is the norm, so it's more accessible because it's routine, whereas perhaps sample C is thinking more emergency care? Lissette, Michael, or Mike, do either one you want to take that one?
Yeah, I can jump in there. Yeah, that was explored in this study. So sample A had more questions in the survey itself, and B and C were 10 questions that we had summary data for, and analyzed that summary data, but some of that shows up in the summary data. So emergency use was an example of who was accessing emergency use. We also looked at the emergency room, I should say. The other one of the other modalities was looking at retail health and urgent care. We looked at primary care, mental health services, drug and alcohol services. So that was detailed out through the survey. Interestingly enough, sample C generally, whether it was even emergency room services or whether it was urgent care, retail health services, were the lowest utilizers of those different types of modalities. So, and that was pretty much across the board. Whereas generally speaking, and Nick will access or send you guys a link to the full report. Generally, sample A was the group that utilized healthcare services in those different types of modalities to the highest degree.
Great. So let's move on to the second section, Lissette. So again, we're going to move on to this action steps, and so the hospital closer group that is now renamed, and we'll get into that, met for the last 3 months. So we had 3 brainstorming planning sessions to say, based upon this survey analysis and based upon what's currently happening in Coatesville, what are some action steps, starting with goals that we can really move forward in terms of this. So I'll turn it back to Lissette.
Great, thanks, Nick. So as Nick said, we kind of reframed and said, okay, based on the recommendations and different strategies that we've discussed. And so in 2023, as we mentioned, the Alliance adopted an anchor strategy plan, which, as you will learn when you go into your 3 breakout groups and discuss, and from our next slides, is divided into the integrated healthcare delivery, the access and engagement, and the social determinants of health. And as you can see, all the different categories sort of intertwine in order to provide this place-based approach for health equity in Greater Coatesville. And so as the group came together, another response was, as mentioned in our timeline, with the ARPA award, was the creation of the Equity Health Center. And so the Equity Health Center really falls into that integrated healthcare delivery that we are providing within the anchor strategy. And in the photo, you see some of our providers that have come together, as well as Maura, who's on the call today, who is our Equity Health Center coordinator. And our partners are listed on here. We have several providers and we have 2 contractors. We start with the Coatesville Center for Community Health. They will be providing navigational services and referral management, as well as with a technology aspect. The Coatesville Youth Initiative will be serving the youth mental health services and navigation and providing pro-social opportunities through referral as well. Community Volunteers in Medicine will be providing a microsite of telehealth for the uninsured, both in primary care and specialty care. We have Chester County Hospital Penn Medicine providing wellness, education, and preventative care at the Equity Health Center. And TMAC providing transportation via a transformation of a fixed route, and also looking at the possibility for on-call transportation services for medical appointments, but also possibly expanding into other broad social services that may be needed. We also have 2 contractors. New Osoma Communications will be providing our marketing and educational materials and campaign, really looking at the different ways with engagement with the community, how to increase access via education and different engagement opportunities. And then an evaluation contractor partner, West Chester University, and their team will be looking at how we move that needle forward from now to 2026 within the Equity Health Center, and looking at that integrated component. The Equity Health Center also has an oversight committee, as you see listed up top, comprised of partners from the community, as well as leaders and 2 representatives from the Alliance. We are very excited about that partnership. They do come together with the providers and discuss different responses, different action plans within the Equity Health Center, and how to best deliver services to the community. As Nick mentioned, the group that came together and really in the past 3 months have been in a very strong planning phase in terms of executing strategies and looking at different goals for the anchor strategy, divided into the 3 sections: the integrated healthcare delivery, the engagement and access, and the social determinants of health, and really define specific goals for what that would look like in the coming year for our anchor strategy. So goal 1 for the integrated healthcare delivery is to increase delivery collaborations and partnerships that effectively address and communicate the continuum of care for Coatesville residents. So hoping in a 20% reduction of chronic conditions, and doing this via early screening, coordination of care, and chronic condition management, really utilizing the 3 strategies within the anchor strategy. Also looking to reduce emergency calls and crisis emergencies by 25% by getting people into the behavioral healthcare system early, and 25% of underserved individuals, providing that knowledge of where and how to get insurance and care by 2026, and really looking at that target number to increase that access. Our second area within the anchor strategy, the engagement and access, is really to remove these barriers of engagement and access, namely the transportation, technology, navigation that Mike discussed earlier that we found within the survey for the Greater Coatesville population. And really this is by prioritizing that underserved population who need to increase their engagement, and hoping that that will result in a 25% increase of utilization of our healthcare services. Also a 25% increase utilization of transportation within the Coatesville ecosystem, and also a 25% increase in utilization of telehealth for these underserved populations, as well as that same percentage for knowledge of where to get healthcare, where to get behavioral health services to all the populations by 2026. And our third area of the anchor strategy that the group has come together to identify clear goals for is the social determinants of health. And really this is divided into 2 sections. The first is employment. So the clear goal here is to increase employment and living wage employment in Coatesville for adults, males and females of color, ages 18 to 64 in particular, by 25% by the target year of 2026. The initial target population will be 100 individuals that are earning less than a living wage, recognizing that that target population will increase as we go along, looking at that target date of 2026. And then increasing housing stability, whether that's home ownership or rentals in Coatesville for adults, also male and females of color, ages 18 to 64 by 20% by that target of 2026. And so again, it was a 3-month planning approach. The Health Equity Group of Greater Coatesville, which is our hospital closure group, created this response in the survey based on recommendations. And this includes goals, strategies, and action steps within the anchor strategy.
And just go back to that slide, Lissette. Just a couple on the integrated health delivery. In the previous slide, when we're back, Lissette. In the previous slide, just to know, is like Chess Pen is not in one of the logos here, but they are in the Oversight Committee, and these were just the ARPA providers in there, but Chess Pen is incorporated into that delivery system. So next slide again. And then to answer the question that was in the chat from Lieutenant Roger Ollis, is one of the goals for the integrated health delivery is looking at the potential of an urgent care in Coatesville. We did talk to a urgent care provider about 6 months ago, and the next step is to meet with that provider, the county, and other and potentially some of the developers to say, is there a site for urgent care in there? But that's one of the goals. We didn't present the goals here or the key action steps here. We wanted to keep this high level for this group to really talk about the goals, but not necessarily the action steps or key performance indicators. So I think I got those questions. And then Carrie asked, are you also looking at Chesco Connect, formerly Rover, to provide transportation? Carrie, I do not believe they have joined, but a great recommendation for us to incorporate them into the Equity Health Center renamed from the hospital closure group. Any other questions before we I'll go into the different groups? Vincent Miles, are there conversations to link food access? Yes, in one of under the access engagement and also in the social determinants of health, one of the action steps is to bring in access to healthy and affordable food. That is, again, another level down in terms of the details of what we're planning. But yes, that is built into the underneath sort of the big goals that we're planning. Okay, so we are going to, you get to self-select into which group you would like to have a discussion. So you'll be able to pick either the integrated health delivery, the access or engagement, or the social determinants of health. Please make your choice. And welcome back, everyone. So we're going to do a quick report back. I will start from our group. I think we were the social determinants of health group. And we really focused on additions to the goals that we had. I think that the three main things are when we focus on put ourselves in the shoes of the residents, there's too many that turnover in terms of that. You have a resident that either is a rental or homeowner or whatever, and then they turn over to new residents or whatever. And there needs to be some consistency in home ownerships or rentals, that the residents stay consistent within that. So we have to put them, and connected to that is the ability to build wealth or increase the value of homes through rehab and something to that extent. The second big point of the social determinants of health when you look at housing is that Coatesville is currently about a 40% home ownership when you compare it to Chester County, which is like 70 to 80% home ownership. And we need to start shifting ours, and that may be required in the code, but really moving that percentage higher to home ownership. So that could be an increase to an addition to the goal. And then, of course, we addressed probably the living wage is transportation. So there's not always that living wage jobs are in Coatesville, but we need to make sure that on the fixed route stuff, that transportation is not a barrier for people having access to those living wage jobs that might be outside of Coatesville, but that Coatesville residents need to have access to those jobs. So it's not just simply about, having jobs in Coatesville, but to say, yes, they should have accessibility outside of it. So those are our three main additions. And why don't we turn it over to Lissette for your report back?
Sure. So our group on access and engagement really shifted toward survey strategies and how often and how to survey the community and what that might mean. And so a few suggestions were brought up, and that's sort of to look at it as a long-term strategy. And maybe first wait until some action steps have been completed so that you could actually survey the community and say, this has been done, maybe reference some events at which the information was collected or the education was provided, and then get their feedback. Others suggested more frequent sort of temperature checks to then specify, which I thought was a great example, is to say, well, we did this at this certain event, and this is what came of it in particular. How do you feel, or what do you think about that? So rather smaller, more micro temperature checks that specify where and when they found that information and what might have come from that. And also the education piece, really, when it comes to survey, one of our participants mentioned that there was a bit of survey fatigue when people don't fully understand where the surveys are coming from, what their purpose is. And so really to focus on that pre-work and provide people with information, but also make sure, to the point earlier, that some action steps are completed or concrete in understanding where we're going. And then finally, a great suggestion, just maybe asking the community when we're looking at the lower engaged populations, what is it that you want for your healthcare? Beyond how do you feel about what has happened? And the phrase was, even if it is pie in the sky, right? But what is it that you want? How can we start there and then take this into solutions? And then Maura, I think, is our last.
So we had the conversation about integrated health delivery. We talked a lot about the integration of that integrated health delivery. Thankfully, our group was very equity health center heavy on the people that were participating in it, but definitely conversations about not only how can we really integrate the services, but ensuring that we have regular meetings and conversations about supporting one another in that health delivery and promoting each other and each other's programs. And then as well, measuring how that coordination of care is happening and how we know how many referrals are happening and who's referring to who and quantitatively how much that's happening. So figuring out metrics and how to measure and collect those metrics is something that we'll be really focused on with the Equity Health Center. In terms of repeating the survey, it was pretty well communicated that every 2 years seems like it would be a good way to keep our temperature check and see how everyone is responding to the programs that we're doing, as well as responding to the lack of hospital or introduction of hospital at some point in the near future. And then some other things we talked about, not quite related to integrated health delivery, was just language access, now moving even beyond Spanish into some other dialects, as well as the logistical phrasing of some of the goals. Reducing chronic health conditions in 3 years seemed a little bit far-fetched. So rather than having that as the goal, changing it to an increase in the number of screenings for those chronic conditions, because we know that the reasons for those chronic conditions are much further dated than the 3 years. But lots of really great feedback from the Integrated Health Delivery Group.
Great. Well, next steps is the official publication. We will release it in a digital format online on our website on June 1st. We will also have printed copies that will be available on June 14th. And we will have many distribution points that include our own offices at the Alliance Health and Equity, the Brandywine Center, and we'll also have it in community sites such as the libraries and other community agencies. So you'll be able to get your print copy if you want, but it will be on June 1st. And also, follow up to this, we will make sure this recording is sent to everybody that registered for this event. So you have a copy of this presentation. And again, we will notify you again on June 1st when it's up on our website, and therefore you can access the report of the survey analysis. And as we said before, more detailed in terms of the goals, strategies, and action steps that the hospital closure group, now named the Equity Health Group, will be moving forward. But we thank everybody for your time, and we look forward to continuing the conversation. Thank you for joining us.
Thank you.
Thanks, everyone.
Thank you.